Right, so this is just a comprehensive presentation on the diseases and disorders of the endocrine system, many of which that are covered in medical, surgical, nursing. We'll cover a number of aspects of the endocrine system as it relates to form and function, and the hormones that are encompassed in the endocrine system, alongside what those hormones do. So first, we have the endocrine system's anatomy. And so the question might be, what does the endocrine system do, and how does it work? So first and foremost, we know it helps us metabolize energy, food sources. It's the way in which we break down food and get energy from the nutrients that we consume. It helps, of course, with growth and development, helps with our emotions, and sometimes it hurts our emotions and mood. Because of the function of hormones, it regulates fertility and sexual function, regulates sleep, regulates blood pressure. So you see in this slide here a couple images that hopefully connect to the function of the endocrine system and its anatomy. It consists of endocrine and exocrine glands, both in females and males, with the main distinguishing characteristic being that in males, of course, you have testes, and in women, you have ovaries. All other endocrine and exocrine glands are the same, including the pineal gland in the brain, the hypothalamus in the brain, the pituitary gland in the brain. Then we move down inferiorly. In the neck, we have the parathyroid gland, which sits on the thyroid gland. Moving down further near the sternum, we have the thymus. And then going into the abdomen, the posterior aspect of the abdomen, we have the adrenal glands that sit right on top of the kidneys. To the left of the abdomen, we have the pancreas. That, of course, helps with the processing of insulin and sugars. Kidneys do play a role in the endocrine system, a critical role in the endocrine system, although they are technically a part of the renal system. But they do have a very significant role with the endocrine function. So the hormones created and released by these glands in your body make up this endocrine system that is essentially control nearly all the processes of the body. So then we have function. On the left, you see a labeled character that has all of the hormones associated with the different endocrine glands and exocrine glands. I'll just essentially give a short rundown on the function of these hormones based on gland. So that adrenal gland that sits right on top of both kidneys has hormones that control growth. It controls sugar metabolism, kidney function, and stress. That hypothalamus that's in the brain, actually at the base of the brain, controls hormones for body function, and essentially regulates all the other glands together with regulating and controlling sexual activity. In women, we have ovaries. Those produce the female hormones estrogen and progesterone. In men, we have testicles. Those produce the male hormone testosterone. Although women do not have testicles, of course, they do have the hormone testosterone. The pancreas, critical part of metabolism, is right at the fold of the duodenum, and it produces insulin. Of course, insulin is needed to regulate blood glucose and the converting of glucose to energy in the cells. The parathyroids, they sit right behind the thyroid gland. They are posterior to the thyroid gland, right in the neck, right there by the windpipe or the trachea. And they control calcium and phosphorus deposits. Then we have the pituitary gland that is found at the base of the brain, helps control growth, development, reproduction, lactation, and stress. The placenta is actually considered an endocrine gland in pregnant women. It is the afterbirth membrane that covers the fetus, and it maintains pregnancy and produces female hormones. And finally, we have the thyroid that controls metabolism and growth in the body. So those are just the basic rundown of the hormones and their function. And you'll see as we progress into the chronic diseases and acute presentations how when these hormones are absent, in excess, or out of balance, they create some significant complications with different types of chronic diseases, and in some instances, emergencies. The first of which is SIADH. To the right, you see a great illustration of essentially what ADH does. ADH is also known as vasopressin, and so it is that hormone from the posterior pituitary gland that works with the kidneys to produce urine. In other words, to create the process of diuresis. This syndrome occurs when above normal ADH levels are in the body. So you have too much ADH that's released, and that causes impaired water excretion. And so you have a risk for retaining water. It's characterized by hyponatremia, concentration of urine, and dilution of blood. And the patient has an adequate amount of blood, but the blood is more dilute than normal. And it causes the body to retain fluids, resulting in your electrolytes really being out of balance. Some of the causes typically of SIADH are a tumor, and in some instances chemotherapy treatment that may lead to this particular syndrome. Some subjective cues that you would pick up on as you're assessing a patient would be nausea, muscle cramps, changes in mood like depression, irritability, and fatigue. Some of objective data that you would collect would be vomiting, hypothermia, tremors, confusion, seizures, coma, edema, and signs of volume overload. Because the key here with SIADH is that the process of diuresis is complicated. It's slowed down, in some instances even perhaps stopped. And so you have this accumulation of fluids in the body, which would give you fluid volume excess. And all the things that are associated with fluid volume excess, like hypertension. We know that renin, aldosterone, and angiotensin assist the body in maintaining blood pressure, but with SIADH, that's thrown off. And so you do have instances where you either present with or have risk for hypertension because of the excess fluids that are retained. Priority actions are going to include initiating 3% NaCl, restricting fluids to 800 milliliters a day, and administering vasopressin antagonist. That's going to produce increased diuresis and lower the fluid threshold that's being retained in the body. Patients may be on fluid restrictions to help balance intake and output, but of course you're going to monitor for retention, looking at the inputs and outputs, looking at their weight day in and day out, monitoring changes in electrolyte balances, because we know they can disrupt, for example, the heart, causing arrhythmias, monitoring for fluid shifts. So, of course, with SIADH, we have too much fluid that's being held in the body. So, when you start treatment, that fluid is going to diurese. But oftentimes, if that diuresis occurs too drastically, you go from one extreme to the other in terms of vital signs. Excess fluid volume can settle in and around the lungs and heart. So you have, of course, the buildup of fluids in the lungs that would present with adventitious lung sounds. Buildup of fluid in the heart, which would present with possibly edema, but certainly overload on the heart. So you're going to monitor for signs of congestion, difficulty breathing, because that means that SIADH has now manifested itself in the lungs. Knowing, though, that this can be triggered by infections, especially pneumonia. So you do need to monitor for the underlying cause of this syndrome. There may be some supplements that are given per provider order to regulate the imbalance in electrolytes. But the main thing is going to be getting those fluids off and out of the body and in a homeostatic state so that electrolytes are balanced and there's not a fluid volume excess. Big risk for hyponatremia because of the lack of diuresis. So the nurse, of course, needs to monitor lab values to determine if the treatment is effective. Another complication that comes with this particular syndrome is going to be seizures. So a critical priority action, especially when this syndrome is progressed in an acute state, is going to be monitoring for cerebral edema. That's that intracranial pressure and fluid buildup in the brain that can cause or exacerbate the instances of seizures. And like I said from the beginning, this syndrome causes the nursing diagnosis of hypervolemia. Critical to look at your ECGs per provider order because of the electrolyte imbalances that can throw off the rhythm of the heart. Again, assessing and monitoring respiratory status because of the buildup of fluid, and monitoring your lab values, specifically potassium sodium chloride and the osmolality of the blood. That's the concentration of the blood. You may also see lab values for urine specific gravity. That relates, of course, to urine function and output, but your key lab values are going to be your electrolytes and the osmolality of the serum blood. Next, we got DI, which is diabetes insipidus, not to be confused with diabetes mellitus or mellitus. As you can see from the photographs that are here, this person is going to be running to the bathroom and reaching for water. Diabetes insipidus refers to the condition where the kidneys are really unable to retain water, and even though the patient may be dehydrated, the kidneys can't really balance the fluid and produce large amounts of insipid urine. And so they're constantly going to the restroom, diuresing. There's polyuria, but the urine is actually very dilute. Normally we know, of course, the kidneys produce 1 to 2 quarts a day, but with this particular condition, you're talking about 3 up to 20 quarts a day of urine that are being produced because of the need to rid the body of high levels of glucose. So patient's going to obviously feel very thirsty and have the urge to drink large amounts of fluids. In this case, for this particular diagnosis, your outcome for this patient is going to be to prevent dehydration. Number one, manage the symptoms and prevent any complications or reoccurrence. It's going to present itself subjectively with, excessive thirst, polyuria, excessive urination, possibly, subjective signs of headache and fatigue and dry mouth. Objectively, as you are assessing a patient, you will likely see, when you're looking at their mucous membranes, for example, dryness. Looking at their skin turgor, it's going to be a decreased turgor. For people of color, you're going to make sure that you're assessing not just their exterior skin, but looking at their mucous membranes and their conjunctiva, looking inside their mouth. Another clear objective sign for DI is going to be tachycardia. Some instances of weight loss, because now you have risk for fluid volume deficit because of the increased polyuria. Hypotension obviously connects when you think about the patho, because of the increased ridding of fluids in the body, you have low fluid volume in the body, and so your blood pressure is going to be low. Hypernatremia, because your body's retaining that salt, and then related to what we talked about a moment ago with turgor, you're going to have a decrease in skin elasticity because your level of fluids in the body is drastically decreased. Weight loss will occur with excess fluid loss, and thirst is going to be a key sign. This is going to present with abnormal blood sugar levels, so you're going to make sure that you're monitoring those glucose levels. Early detection and intervention are key, because when not treated early and often, this can definitely lead to hypovolemic shock. So you're going to assist the patient when standing, because when you've got low blood pressure, just like with orthostatic hypotension, you've got a risk for falls, risk for injury. So safety and fall precautions are going to be critical. Educating the patient on slow position changes, just like, if they had orthostatic hypotension. In this case of DI, they have regular hypotension. So slow position changes. If they do have intact thirst and they're not NPO, of course you're going to provide them water, preferably, to stay hydrated. But in most instances, especially inpatient, you're going to have IV fluids, and so you're going to need to set up an IV, assess that IV site, and maintain normal saline or another fluid per provider order. Monitoring electrolytes is going to be key because when excess fluids are lost, the body begins to secrete potassium and hold on to sodium. So that comes with, of course, dietary changes that have to happen. Can't eat sodium if you're hyponatremic. Again, fall precautions, so assisting with ambulation, making sure a bathroom is accessible and nearby and they know where it's at and how to get to it, or at least know where the call light is and how to ask for help because of the polyuria. And that's in the cases where they don't have a Foley catheter. If they do have a Foley catheter, then do expect to monitor IOs and prepare to do frequent changes or emptying of that catheter bag because of the increased diuresis. Also, one thing to consider as a nurse with DI is because of polyuria, especially in geriatric patients or patients with disabilities, there's a risk for incontinence, or there may already be incontinence. So you need to assess skin integrity and monitor for skin breakdown, helping them with ADLs and skin hygiene so that they don't get any skin breaks or ulcers, because that's a increased complication for patients with diabetes, because we know how high glucose levels slow down the healing of wounds. Next, we've got hypothyroidism. It's a common condition, very common condition, where essentially the thyroid gland does not produce enough thyroid hormone. Talked earlier about what the thyroid hormone does. So in this case, you don't have enough thyroid hormone being naturally produced in the body. That's going to affect essentially every organ system in the body. Because when the body doesn't have enough of those hormones, all of the body's functions begin to slow down. One thing that I do to associate hypothyroidism with the types of physiological changes that happen is, slow down has two O's, an O in slow, an O in down, and hypothyroidism has two O's. So think of those O's in hypothyroidism as slow down, because that's essentially what happens to the functions of the body. While of course can happen to anyone, women are definitely at risk for hypothyroidism, and those between the ages of 30 to 60 are more at risk as well. Usually if you have a genetic disorder like Turner syndrome, you're more at risk for hypothyroidism, as well as any instance of a goiter or thyroid surgery. Diseases such as lupus and rheumatoid arthritis, or type 1 diabetes even, can put someone at risk for hypothyroidism. Desired outcome for a patient that's experiencing hypothyroidism would really be decreasing the amount of fatigue, optimizing their energy level, and optimizing their metabolism. Because again, think of slow down, the O in slow, the O in down, the two O's in hypothyroidism. Everything begins to slow down. And so you have fatigue, weakness, definitely have sensitivity to cold, are likely to see changes in mood. Many of these icons here, all of these icons actually relate to some subjective and objective data that you'd collect for patients like this. So you'll see weight gain, you'll see hair loss, you'll see restlessness and depression, decreased sexual function or decreased libido, possibly memory loss and muscle cramps. All of those are associated with the decrease in thyroid hormone. So when you think hypothyroidism, you're going to think weight gain and cold intolerance. In contrast, hyperthyroidism is the exact opposite of hypothyroidism, and hyperthyroidism is going to have weight loss and heat intolerance. So hypo, slow down, low, you're going to have weight gain and cold intolerance. Visually, I connect the O in cold with the O's in hypothyroidism. That helps me memorize that hypothyroidism is connected to cold intolerance. The decreased thyroid hormone levels slow all these body processes, and so you're going to have slowed respirations and cardiac output. Monitoring vital signs is going to be a given, especially monitoring for bradycardia and decreased respirations and the complications that would come with that. Energy level is going to be critical, monitoring and assessing for that so that you know whether they need assistance with ADLs, whether there needs to be additional precautions around falling and assistance with ambulation because of their gait that may be weak or their strength that may be decreased. Because one of the biggest complaints with hypothyroidism is fatigue. So you need to encourage your patients to engage in self-care and activities when they're at their highest level of energy. Levothyroxine is a common thyroid medication that is prescribed for hypothyroidism. And in more cases than not, it's a lifelong medication that they must take for the rest of their life. You're going to need to encourage them to monitor their food intake and make healthy choices around their diet. Assessing their skin integrity for moisture, because of course, this comes with cold intolerance. It also comes with dry skin. So you may need to help them with ADLs as it relates to maintaining adequate skin turgor and hydration, and making sure that their environment, their room is comfortable. They might need a blanket, might need their heater turned on or AC turned off to be able to limit cold exposure. So next we have myedema coma, not to be mistaken with an actual coma because it doesn't necessarily present itself as a loss of consciousness. But myedema coma is an exacerbation of hypothyroidism. So essentially there's insufficient thyroid hormone or there's not enough supplementation of thyroid hormone. And so it leads to a state where there's deficient T4, deficient T3, and they're in a life-threatening condition. So patients with this particular disease will present to the hospital because it is something that occurs when hypothyroidism is untreated or undiagnosed. You may notice that they have diminished hearing, of course, cold intolerance, just like hypothyroidism, fatigue and lethargy. Objective symbols or objective signs, rather, would be hoarseness of their voice, unresponsiveness, decreased breathing or respirations, hypotension, hypoglycemia, and hypothermia. They should be treated in the ICU because their number one priority in terms of therapeutic monitoring would be assessing and monitoring their heart. So they'll have an ECG that continuously monitors their heart, so they'll be on telemetry. It may be an instance where there's a provider order for a 12-lead ECG. But the initial steps in this instance of myedema coma is to maintain a patent airway. So airway management is number one. Then, of course, per provider order, replacing the thyroid hormone because there's hypothyroidism to the 10th degree, so you're going to need to replace the thyroid hormone that's no longer there or not in adequate levels. And typically there are going to be additional supportive measures like a prescription or provider order for glucocorticoids that are administered to help with the immune response and inflammation. I will tell you, though, it's very important to watch for signs of toxicity of levothyroxine. Levothyroxine is your most common thyroid medication used for hypothyroidism. The brand name is Synthroid. So in any instance where you're treating hypothyroidism, especially an acute presentation like myedema coma, you're going to look for toxicity. Toxicity to levothyroxine is going to look exactly like hyperthyroidism, which is we're going to talk about next. And so you're talking fast heart, feeling hot, sweating. So that's the complete opposite of hypothyroidism, where they're cold and clammy. So monitoring for that signs and symptoms of toxicity is going to be critical. If they are hypoglycemic, of course, make sure that that's a part of their documentation and the provider's aware, because oftentimes you're going to administer glucose or use the 15-15 rule and give them 15 grams of carbohydrates. Because this is just an acute presentation of hypothyroidism, you're going to keep them warm. So, of course, you might need some blankets, might need to turn off the air, might need to turn on the heat, excuse me, because of their intolerance to the cold. Another thing when it comes to provider orders in the MAR, it's going to be contraindicated to give them sedatives or muscle relaxants or narcotics or anything that's going to suppress or depress the CNS. Because people that have this particular state of acute hypothyroidism are very sensitive to those sedatives. Again, this is all about having a low thyroid. So every process in the body regulated by thyroid hormones are drastically decreased. So again, priority number one is your ABCs, making sure you have a patent airway. And then we have hyperthyroidism. So this is where you have a chronic increase in T4 and T3. You see in this picture an instance of bulging eyes, which is a common symptom when hyperthyroidism is undiagnosed and or untreated properly, as well as a goiter that presents right there where the thyroid gland is anterior in the neck, right by the windpipe. Critical for you to monitor their vital signs, especially looking for orthostatic changes in vitals, including their heart rate and their blood pressure. It's oftentimes easier to assess BP or sometimes necessary to assess BP and pulse during their sleep, so you can rule out other causes and determine whether there are cardiac arrhythmias. You may likely see a provider order for a 12-lead ECG, where you have to monitor their cardiac rhythm, because now we go from hypothyroidism, where you didn't have enough thyroid, so things are slowing down, to the exact opposite. You've got a whole bunch of T4 and T3, and everything's sped up. And so cardiac activity has to be monitored. You're going to assess respiratory status and auscultate lungs, especially looking for any crackles, rails, wheezing, rhonchi. Essentially any adventitious breath sounds are going to need to be assessed for and monitored, because they could be indications that now you have cardiac involvement of fluid on the lungs. Encouragement of eye protection like sunglasses and eye drops, including over-the-counter eye lubricants and perhaps even provider order for eye drops that protect the eyes. And there are also treatments that help in reducing thyroid eye disease that is associated with hyperthyroidism. Finally, as it relates to one of the common treatments for hyperthyroidism is perioperative care. So thyroidectomy is where they essentially remove the thyroid. You're going to need to prepare the patient for surgery and monitor after surgery for swallowing and excessive bleeding. Following any thyroidectomy, you're going to make sure that they are in a semi-Fowler's position, never laying flat, especially because they're at risk for a compromised airway. And after any thyroidectomy, you're going to need to monitor the circumference of their neck. So you're assessing for swelling, increase in size, and post-op edema, because again, that puts them at risk for asphyxiation and eventually death, because of the airway being closed due to swelling. Of course, you can imagine in terms of nursing interventions around perioperative care, you're going to need to make sure that you help them maintain adequate cardiac output, decrease their level of fatigue, and have optimum skin integrity. Some pointers here for hypothyroidism is, unlike hypothyroidism, now you got weight loss and heat intolerance. Again, protruding eyes is a hallmark symptom and often results in dry eyes, as well as risk for damage in the cornea. I'll also say, in terms of treatment, there are anti-thyroid drugs that are prescribed. Another treatment is radioactive iodine, as well as beta blockers. Beta blockers don't really have any action on the thyroid hormone itself. It just treats those symptoms of increased thyroid hormone. So it slows the heart down, because with hyperthyroidism, you got tachycardia. It decreases the amount of nervousness and shakiness that come with hyperthyroidism as well. A key point here in terms of medications and management of patient symptoms is that in pregnancy, any diagnostic tool such as a thyroid scan is contraindicated. Diagnostic tools such as, or diagnostic tests such as radioactive iodine uptake tests are contraindicated in pregnancy as well. You're going to need to make sure that you've got that emergency trach kit around the bedside, because if you do have excess swelling that cuts off the airway, there's going to need to be an emergency tracheostomy to make sure that that airway is maintained. Let's see if I can think of anything else. Hormone replacement, because of the hormones that are off whack. You're going to need to provide encouragement and emotional support because of the potential changes in disturbed body image, as well as possible changes in sexual function. And if they are taking an anti-thyroid medication, they never should stop it abruptly, because that can lead to a thyroid storm. And they do not or should not take aspirin with this prescription. So avoid aspirin if they're taking any anti-thyroid medicines. If they are taking your radioactive iodine or just any anti-thyroid medicine in general, they're going to need to avoid medications that have iodine or foods that may have iodine in them. It's going to be contraindicated. And the extreme instance of hyperthyroidism is what we call thyroid storm. Thyroid storm. So that's an extreme instance of hyperthyroidism. It's exactly like hyperthyroidism, but it is in an acute state, and it is a life-threatening emergency. Someone with thyroid storm, or anybody even suspected of thyroid storm, is going to need emergency treatment immediately. They're going to need cardiac monitoring. Intubation is going to be possible with ventilation for supplemental oxygen, as well as priority of using IV fluids. This patient requires immediate implementation of anti-thyroid medications that will help regulate and reduce the thyroid hormone that's circulating, as well as the symptoms associated with hyperthyroidism, as well as possibly seeing provider orders for corticosteroids and beta-adrenergic medications. History is going to be important here, making sure if they have a history of asthma or currently diagnosed with asthma. That's going to be key with your therapeutic regimen, because there are some contraindications with beta blockers, for example. So they can't get those beta blockers if they have asthma or a history of asthma. In general, your signs of thyroid storm are going to be an elevated temperature, nausea, and tremor. So you're going to monitor and assess for vital signs and pay very close attention to their temperature, looking out for fever. Essentially it's just very severe signs of hyperthyroidism. Then we have adrenal insufficiency. We have primary adrenal insufficiency, also known as Addison's disease, and we have secondary adrenal insufficiency. So this is where we don't have enough cortisol and we don't have enough aldosterone. Okay? Typical causes include infection, like tuberculosis, autoimmune diseases like lupus, or damage to the adrenal glands, like trauma or surgery. So, of course, cortisol levels are low, aldosterone levels are low, and you might even have an instance where there's an adrenal hemorrhage that causes this as well. But it's going to result in weight loss, because when cortisol levels are low, weight goes down. So you're going to need to monitor weight, monitor IOs, increase fluid intake. Make sure that they're maintaining an adequate amount of sodium in their diet. Minimizing stress and overexertion. So planning out a schedule for their ADLs and other activities like PT or OT to make sure that they can tolerate the physical exertion because of their level of fatigue that is associated with this particular disease. Vital signs are clearly going to be a priority here, especially around fever. And fever has to be treated with acetaminophen or another antipyretic, but it cannot be treated with something like aspirin. That's going to be contraindicated with this disease because of the other medicines that are usually taken. And a priority is going to be monitoring for signs of hyperkalemia and using that EKG or ECG per provider order to monitor cardiac function and cardiac rhythm. Next, we have Cushing's syndrome or Cushing's disease. There are two different types of presentations of this diagnosis. So you have the syndrome, which is not as severe, and then the disease, which is chronic. In the instance of Cushing's syndrome or disease, you have an overproduction of ACTH in the anterior pituitary. And so now you've got a stimulation of cortisol release from the adrenal cortex, usually caused when there's a tumor, a cortisol secreting tumor, usually in the lung, for example, that destructs the adrenal glands. There may be adrenal carcinoma, which is cancer of the adrenal glands, or a pituitary cortisol secreting adrenal tumor that may be benign, non-cancerous. Cushing's disease is usually caused by a tumor or excess growth of the pituitary gland, just regular old hyperplasia, an enlarged pituitary gland. Cushing's syndrome is similar in that you have, of course, the excess cortisol, but it's usually a result of other disease processes. So Cushing's syndrome is very similar, will present similarly, but the causes are different. The Cushing's syndrome causes are more metabolic, whereas the Cushing's disease causes are related to a tumor or hyperplasia of the pituitary gland. Priority outcomes for this patient in terms of goals as you're doing care planning is manage symptoms. Make sure you're maintaining a normal blood pressure based on their baseline and a blood glucose level within appropriate range. They may present with some subjective cues of back pain and weakness, irregular menstrual cycles or lack of concentration. They obviously will have some objective symptoms that are going to clearly indicate either Cushing's syndrome or disease. So things such as a very round face, upper body obesity. So their legs and their peripheral extremities are thin, but their torso and upper body are large. Skin infections like acne, hypertension, diabetes that's not controlled, so hyperglycemia, tachycardia, and tachypnea. Excess cortisol can cause blood sugar to fluctuate. So monitor blood glucose levels regularly and notify the provider if it is outside of the patient's range. Obvious signs of infection, of course, would be masked with corticosteroids. So take note of subtle signs, monitoring for fever, and vital signs in general. The client with Cushing's syndrome should be reassured, though, that the physical changes of this particular disorder do resolve with treatment. So Cushing's syndrome, which is usually a metabolic cause, can be reversed in terms of the changes in physical symptoms, like the moon face and what's called a buffalo hump, the stretch marks that may present in the abdomen, and the bruising that shows up in the peripheral extremities. Then we have good old diabetes mellitus, DM for short. So with diabetes mellitus, there are two primary types of diabetes: type 1 diabetes, type 2 diabetes, and then we also have our little talked about but very important diabetes called gestational diabetes. Type 1 is genetic. It's autoimmune, immune or even triggered early in life from a viral infection, really. But essentially, type 1 diabetes is where the cells attack the insulin producing cells in the pancreas. And so now you no longer have the production of insulin. Whereas with type 2 diabetes, because of metabolic changes and lifestyle choices, the body becomes resistant to insulin. So it still produces insulin. It may even decrease the production of insulin. But the key here is because of lifestyle choices, including, for example, hypertension and obesity being a critical one, now the body no longer responds to the insulin that the body produces. In contrast, you have type 1 diabetes where the cells of the pancreas that produce insulin are destroyed. And so they no longer produce insulin. Type 2 diabetes, they do produce it, body doesn't respond to it. Gestational diabetes is critical because it's one of the most prevalent diseases among pregnant women that come with some serious complications in pregnancy. If I'm not mistaken, there's about 15 to 25% of pregnancies worldwide that present with gestational diabetes. So your symptoms are going to be everything related to hyperglycemia. So excessive thirst, fatigue, wounds that heal slowly or not at all, changes in vision, changes in weight, and certainly your glucose levels are going to be high. Note, though, as a nurse, as you're providing care, the provider will make a target blood glucose level for them that likely will not be the same as the normal value or normal range. So make sure as you are monitoring their glucose that you're monitoring it in relation to their baseline and their target blood glucose levels. Typically, especially if they're on insulin, there's a sliding scale that is used as well. You also need to teach the patient or reinforce for the patient how to monitor their glucose levels and making sure they know to call their primary care provider if they have glucose levels that are higher than their target for multiple days or any consecutive readings of 300 milligrams per deciliter or more. Another important thing, of course, patient teaching is teaching them how to use the glucometer and record their results, paying close attention to instances where they may have developed diabetic neuropathy, because that's going to change their ability to do many of their ADLs, but especially their ability to properly monitor their glucose with a self-stick glucometer. So in that particular case, it may be indicated to use a long-term monitoring device that are oftentimes being prescribed now, where they don't have to do the daily sticks or the multiple sticks in a day. There's a device that's placed on their epidermis, and it has a small needle that goes into the subcutaneous tissue, and usually through a device or their cell phone, they can read their blood sugars. So that's going to be something to advocate for with the patient, especially one that is older with neuropathy or impaired vision or any type of disorientation like dementia or lack of support at home, because oftentimes a complication of diabetes is not knowing the blood sugar level and not properly managing intake of insulin and or your anti-glycemic medications. Some critical points here that I'll add is the patient's glucose should be checked once when the patient wakes up, before meals and before going to bed. You're going to increase water intake if the patient has hyperglycemia. Both decreased blood flow to the feet as well as neuropathy occur, and so that ends up having to make the feet something the patient really needs to watch. So they likely are going to need a referral for care with a podiatrist. So you're going to also monitor, though, their feet if they're inpatient, monitor their skin integrity because of the delayed wound healing that is associated with hyperglycemia. Hyperglycemia, really, those high levels of glucose in the blood inhibit the blood vessels' ability to heal at a normal pace. So wounds are hard to heal, have a hard time feeling their feet because of neuropathy. So teach them to check their feet every day. If you're going to apply lotion, a moisturizer like lotion, don't apply it in between their toes, because that can result in increased friction and impaired skin integrity. You're going to instruct them to make sure that, of course, hopefully they have an exercise routine. And in that event, they're going to monitor their glucose levels before exercising, while they exercise, and after they exercise. Because that's usually when you see changes in glucose levels and instances where you have hypoglycemia. They do need, of course, to know the signs and symptoms of hypoglycemia and hyperglycemia. So that's a critical part of patient teaching. In terms of administration of insulin, regular insulin, the U100 strength at least, can be administered via IV, particularly IV bolus, IV push. I will also say some short duration insulins like Lispro, Aspart can be used via IV infusion. You want to make sure that you're assessing for lipodystrophy. So looking at their subcutaneous tissue to see if there's any breakdown in tissue where they are not switching up the injection site, any redness, swelling, or irritation, or erythema, and then reinforcing that they need to change their injection site because that can result in tissue damage where the skin integrity is impaired, and of course they're not absorbing the insulin medication. In diabetes, you want to prevent any type of moisture from accumulating anywhere on their body. Like I said earlier, especially when it comes to foot care, which is very important, making sure that when they're bathing or showering, they're drying between their toes. If you or another provider or caretaker or themselves are applying lotion to their feet, making sure that they do not apply them between their toes, because that's a instance of moisture. Critical medication tip here in terms of metformin. So metformin needs to be withheld temporarily before and for 48 hours after any radiological study where they're going to get a contrast dye. So a CT scan with contrast, they need to have their metformin withheld before and 48 hours after that imaging study that involves dye. Now, if there's no involvement of intravenous dye, then they're going to take their metformin as normal. But if they're getting any type of radiologic study or imaging that has contrast dye, intravenous contrast dye, then you've got to withhold the metformin before and after. Another key point in terms of medications, insulin glargine cannot be mixed with any other type of insulin. Insulin should never be frozen, should never be kept in direct sunlight, and definitely shouldn't be kept in a hot car. But if a vial of insulin will be used for up to a month, it may be kept at room temperature. So if a vial is going to be used for up to a month, it can be kept at room temperature. Otherwise, the vial of insulin should be refrigerated. Just some key pointers here as it relates to monitoring blood sugar. H1C is really just a reflection of how well blood glucose levels have been controlled for the past 3 or 4 months. Poor glycemic control is essentially one of the biggest complications of diabetes and comes with an increase in H1C levels, HA1C levels rather. High serum glucose contributes to osmotic diuresis, so you have the polyuria that is associated as the body's trying to get rid of glucose that's at excess levels. That also puts them at risk for dehydration. Also, a hypoglycemic reaction may occur in response to exercise. So, as I said previously, they need to exercise either an hour after meals or an hour after consuming a 10 to 15 gram snack of carbs or liquid carbs, and of course monitor their glucose before, during, and after exercise, because that's usually when complications occur. Let's see, insulin should never be stopped. It may need to be increased during times of illness, and the most effective measure for testing blood glucose is to test it before a meal and at bedtime. Doesn't mean you don't test in other times, but that's the most effective measure of it. Let's see, a couple more things I do want to point out. Meals should be approximately the same time each day. That'll help maintain stable blood glucose levels. Any variation of 30 minutes to an hour is not going to be a significant issue, but helping to have stable glucose levels, of course, helps control diabetes better. So having meals around the same time every day does help. But do note that when the client's under stress, including physiological stress like an infection, an increase in the dose of insulin may be required. Of course, that's going to come with a provider order. That's not something a nurse is going to do on their own. But instances of increased stress or infection may require increased insulin dosage. And glucocorticoids should be used with caution in patients with diabetes because they mask the signs of infection and they have sugar. DKA is diabetic ketoacidosis. That is a emergency event, a serious complication of diabetes that occurs when uncontrolled blood sugar rises and the body really can't produce enough insulin to regulate it. And essentially what happens is the body begins to break down its own fat cells because it needs that energy. It converts that fat cell into ketones, which is associated with the buildup of acid in the blood. Pretty severe, life-threatening condition, and most oftentimes occurs with type 1 diabetes, but can occur with type 1 or type 2 diabetes. Not just limited to type 1, but is most often present in type 1. So that's key there. A key presentation symptom is your Kussmaul respirations. That's basically a compensatory mechanism where the body's trying to compensate for the increased acid that is present in the body. And so you'll have very rapid but deep respirations. Those are called Kussmaul respirations. The symptoms of DKA are similar to the symptoms of hyperglycemia, including vision changes, polyuria, high glucose. But the key here is, unlike hyperglycemia, you're going to see ketone levels. They're oftentimes assessed in the urine, but they can be assessed in the serum blood. But in any instance, it is going to be DKA if they do have ketones in the blood or the urine. And in this case, you're talking about blood glucose levels that are in the 300s or higher. That's going to be a primary indicator when ketones are going to be produced. Monitor these clients who are being treated for DKA because they are at increased risk for intracranial pressure, which comes with cerebral edema, which of course is life-threatening. And the priority treatment, though, for DKA is going to be maintaining fluids because of dehydration, but also restoring electrolytes and administering regular insulin. Typically, you're going to have an IV bolus of insulin, might even have a bolus of nasal saline, normal saline, not nasal saline, normal saline, because the priority treatment is going to be restoring fluids and electrolytes and regulating those glucose levels. Now, what I will say, though, in terms of DKA, oftentimes there is an underlying trigger that is associated with, for example, an infection. So monitoring vitals, especially assessing for fever and other signs of infection, are going to be necessary in this acute state of increased blood sugars. Pretty similar to DKA, but distinguished because with HHS, you do not have acidosis. You do not have ketones in the blood. Very similar symptoms other than you don't have acidosis and ketones. So you're not going to have the compensatory Kussmaul respirations. You're not going to have the acetone smell to the breath, which is a sweet odor or sweet smell to the breath that is associated with DKA. One thing to help you remember, treatment options in terms of endocrine disorders is when they're high, dry, and hot, it's time for an insulin shot. So high, dry, and hot, time for an insulin shot. And that's going to be in the instance where their blood sugar is entirely too high. The primary goal of treatment in HHS is to rehydrate the client to restore fluid volume and to correct electrolyte deficiency. That's the primary goal of treatment. Rehydrating for restored fluid volume and correcting electrolyte deficiencies. And finally, the major difference again is HHS versus DKA. When it comes to HHS, there's no ketosis, there's no acidosis. Hypoglycemia. So a great way to remember this particular endocrine disorder, or not really a disorder, rather a state of being for endocrine function, known as hypoglycemia, is when they're cold and clammy, give them candy. Cold and clammy, give them candy. So if their blood sugar is low, they're going to need some type of sugar, be it a carbohydrate or a simple sugar, to bring that blood glucose up. So you're going to assess their mental status. That's key because their mental status and level of consciousness is going to dictate how you're going to treat them, because you got to replace their glucose. But how you replace it is going to be predicated on whether they're awake, alert, and oriented. So once you determine their mental status and level of consciousness, you'll check their blood glucose. And if it is indeed below 70 and they are hypoglycemic, then you're going to use the 15-15 rule. So you're going to feed them 15 grams of a fast-acting carb, usually a liquid like orange juice or cookies. You're going to wait about 15 more minutes, and then you're going to check the glucose again. And you're going to wait for that glucose to get above 70. So you may need to repeat the 15-15 rule. Feeding that patient 15 grams of a fast-acting carb, waiting 15 minutes, and checking the glucose again. If they are not awake, alert, and oriented, so in any instance where they are unconscious or semi-conscious, you're not going to give them anything by mouth to eat, because of course that's going to create a choking hazard in aspiration. So you're going to administer glucagon if they are unconscious or semi-conscious. You won't use the 15-15 rule necessarily there. You're just going to give them glucagon to bring their sugars up. The biggest thing, though, with hypoglycemia is preventing it. So patients need to know the signs and symptoms. They need to know how to monitor their diet, monitor their insulin intake, monitor their blood glucose levels, so that they know how to avoid any instance where they have abnormal glucose. So whether it's hyperglycemia or hypoglycemia. You're also going to monitor for signs of infection, because in instances where there is abnormal levels of glucose, whether it's hyperglycemia or hypoglycemia, instances of infection could create some bigger complications than if glucose levels were regulated. And now we're moving on to the thyroid. So hypoparathyroidism. So hypo. It's another one of those things where the O helps me remember low. With hypoparathyroidism, you have an underactive parathyroid gland. So you have low PTH levels. When you have not enough PTH, you don't have enough calcium. When you have not enough calcium, the nerves become crazy and excited, which leads to muscle spasms. Technical name for muscle spasms is tetany. They're also at an increased risk for cardiac arrhythmias, seizures, and phosphorus levels that are abnormally high. So, with hypoparathyroidism, hypo means low. Hypoparathyroidism has low PTH levels and low calcium levels. So you're going to monitor calcium and phosphorus levels with parathyroid disease. Hypoparathyroidism may require a high calcium, low phosphorus diet, which comes, of course, with a provider order and prescription for vitamin D, possibly even a thiazide diuretic to protect the kidneys from vitamin D. Hypothyroidism should be cared for with a warm environment. Thyroid replacement therapy, proper fluid and fiber intake, and monitoring for chest pain. If you do note chest pain, that's a huge red flag where you have to contact the provider first. Muscle spasms, also known as tetany, is related to the malfunction of the parathyroid, and it's caused because there's not enough calcium in the body. Calcium helps in maintaining muscle fiber rigidity and maintaining muscle fiber tone, and when those levels drop, that those muscles begin to spaz out. You will see what's known as Trousseau's sign, which is basically when you go to do a blood pressure check, their wrist will sort of bend inward towards the midline of the body. So that's a key sign of hypoparathyroidism, that instance of muscle spasm and tetany in their wrist, where you're going to check their blood pressure, especially with a manual BP cuff, and just involuntarily their wrist flares toward the body and turns towards the body. Another instance would be Chavoskis. I'm saying that wrong. Chavoskis sign. So essentially, when you tap on the facial nerves, just either bilaterally or unilaterally, just using your hand or fingers to tap on the facial nerves, you'll notice that the facial nerves require or result in twitching of the eyelid, eyebrow, or the face in general. So it's this involuntary twitching that occurs with hypoparathyroidism when you're palpating the facial nerves. It doesn't happen when you don't palpate it necessarily, but when you palpate the facial nerves somewhere around the jawline and the eye, you usually will see twitching, involuntary twitching, unilaterally or bilaterally in the eye area, or sometimes even in the lip area. Because of this, you're going to always monitor for fall precautions. If they've got issues with muscle spasms and tetany, they're at risk for injury. They're at risk for falls. Usually what happens is a provider is going to administer or order them to be administered a supplement of calcium. Vitamin D is common, and then because of the risk of cerebral edema and seizures, they may prescribe an anti-epileptic medication to prevent seizures. And at the other end of the spectrum, we have hyperparathyroidism. So complete opposite. We go from low calcium to high calcium. We go from low PTH to now we're having high PTH. Usually caused by cancer or tumor, a benign tumor. Thinking back to pathophysiology or anatomy and physiology in general, the PTH makes the bones release calcium into the blood. Then what happens is the intestines absorb the calcium and the kidneys retain the calcium and excrete amounts of the calcium into the urine. Well, when you got too much PTH, you've now got increased levels of calcium in the blood. So your nerves go from being normal when calcium levels are normal to now being decreased in their excitability. You've got now risk for some complications with the cardiac system because you've got calcium deposits in the blood vessels that can cause hardening of the arteries. That can also create some vasoconstriction and lead to hypertension. That can also create some coronary artery disease, as well as, because of the calcium that is at increased levels in the serum blood, you have increased risk for kidney stones. So hyperparathyroidism, too much PTH, too much parathyroid, too much calcium. And so now, instead of you having excitability of your nerves and muscle spasms, now you got the complete opposite. And it's definitely going to impair kidney function. So monitoring renal function is going to be key. Monitoring cardiac function is going to be key. Monitoring electrolytes is going to be critical as well, because it oftentimes results in low phosphorus levels. So hypoparathyroidism may require a drug called furosemide, and that'll help with lowering calcium levels, or it may require a drug known as calcitonin that'll help lower calcium levels. Hyperparathyroidism is associated with bone pain. Bone pain is associated with this disease, and polyuria because of the increased levels of calcium. And in this particular disease, patients should increase their fluids to about 1 to 2 liters a day. That'll help with preventing those kidney stones. Because of the increased calcium, they're at increased risk for kidney stones, so they're going to need to increase their fluid intake. And finally, they're at risk for UTI because with the increased level of calcium in the blood and in the urine, their urine is now alkalotic. And we know bacteria feed off of alkalotic blood. Bacteria feed up, well, they do feed off of alkalotic blood, but in this instance, with risk for UTI, bacteria feed off of alkalotic urine. And so because the urine is high in calcium and it's alkalotic, they're at risk for a UTI. That's critical to know. So monitoring I's and O's, assessing for things like dysuria and polyuria are going to be key. Assessing for hematuria is going to be key, and just overall monitoring for infection. And one of our last diseases that we'll talk about is diabetic neuropathy. Similar to other types of peripheral neuropathy, but in this instance, there's nerve damage because of the high glucose levels, the unmanaged diabetes. We know high levels of glucose injure the nerve endings in our body. They injure the blood vessels in our body. And so most often this occurs in the extremities, specifically the legs and the feet. American Diabetes Association actually recommends that any patient with diabetes, specifically type 1 diabetes, be assessed for diabetic neuropathy on an annual basis. So if you've got a patient with type 1 diabetes or type 2 diabetes, they need to be assessed for DPN annually. Similar assessments may, of course, come with those who have hyperglycemia, such as prediabetes, because they're at risk of having diabetic neuropathy as well as developing full-blown type 2 diabetes. The following drugs, though, help manage the pain associated with DPN, and these are going to be drugs that are not your typical anesthetics or analgesics. So things like your SNRIs and your TCAs, which are actually pharmacologically, they're actually antidepressants, but they do help with the functioning of the neurons in terms of decreasing sensations of pain in the periphery of the body, specifically the legs and feet. And our final disease that we'll talk about is pancreatitis. Usually presents itself in an acute state where it is an emergency. Self-digestion of the pancreas occurs, basically causing inflammation of the pancreas. It can be caused because of an obstruction, like a gallbladder stone, that will lead to inflammation. Gallstones that, of course, could potentially block the pancreatic duct. But essentially, the enzymes within the pancreas are prematurely activated, and they start to reflux and come back into the pancreas and cause inflammation. That inflammation quickly leads to erosion and necrosis of the pancreas. Big risk here is for mortality and hypovolemic shock. It may be associated with hypotension and could lead to multi-organ dysfunction, also known as multi-organ failure. Acute pancreatitis is usually sudden in onset and lasts a short time, while chronic pancreatitis is more long-lasting and happens usually after at least one acute episode has occurred. Abdominal pain, especially in the mid-epigastric level, left of the umbilicus, that radiates to the back is a common subjective cue. Anorexia or weight loss or failure to eat, failure to thrive. Nausea and vomiting are also common. Focus assessment is going to be critical. doing a focused abdominal assessment is going to be critical in palpating all four quadrants of the abdomen, assessing for abdominal distension, looking for guarding, and any other signs and symptoms of abdominal pain are going to be key. Objective data or objective cues include, for example, vomiting, fever, dry mucous membranes, tachycardia, and hypotension. Priority here is going to be managing pain, monitoring vitals, and then per provider order, treating the underlying infection, inflammation, and or fever. This is usually associated with alcohol use, and so if it is known to be associated with alcohol use and they are inpatient, then you need to prepare for alcohol withdrawals and the related alcohol withdrawal symptoms, and the need to contact the provider when they demonstrate those symptoms to start treatment for alcohol withdrawal. So if pancreatitis is associated with alcohol use and they're now in an inpatient setting in a Med-Surg unit with pancreatitis, then you need to anticipate alcohol withdrawal and the signs and symptoms associated with it so that you can contact the provider if they do present themselves. That's enough of the diseases and acute presentations. Now we're just going to do a quick review just of the hormones and the symptoms. So essentially when homeostasis is out of whack and there's too much of a hormone or not enough of a hormone, we'll talk through what that looks like in terms of symptoms and presentations in real life for all of your hormones. So we'll start first and foremost with the adrenal gland that is responsible for cortisol. Too much cortisol, you've got weight gain. Not enough cortisol, you've got weight loss. Too much cortisol, you've got stretch marks, fatigue. Not enough cortisol, you've got inability to fight stress. Aldosterone, released by the adrenal glands. Too much aldosterone, you got high blood pressure. Not enough, you've got dizziness, you've got hypotension. DHEA is another hormone. Too much, you got excessive hair growth. In men, you've got enlargement of the breast, known as gynecomastia. Not enough, DHEA, you've got fatigue. You've got emotional changes such as depression, possible changes in sexual function like decreased libido. Pancreas, responsible for insulin, glucagon, and GLP-1. So, not enough insulin, you got diabetes. Too much insulin, you got fatigue and weight gain. Not enough glucagon, you got hypoglycemia and weight gain. Too much glucagon, you got diabetes. GLP, not enough GLP-1, you got diabetes. Too much GLP-1, you got weight gain. Thyroid, responsible for T4 and T3. When there's too much T4 and T3, you've got fatigue, anxiety, and sweating. When there's not enough, you've got fatigue, depression, and weight gain. Finally, we got the parathyroid, PTH. Too much parathyroid hormone, you've got abdominal pain, fatigue, and depression. Not enough, you've got tingling and depression. And vitamin D, controlled by our kidneys. Too much vitamin D, you got fatigue, depression, and bone pain. Not enough, you got muscle pain and fatigue.